our mothers while they are in the journey of pregnancy and delivery. I'll start with a few definitions just to offer context. The spontaneous rupture, let me talk about pre-labor rupture of membranes, which we know as PROM, which is the spontaneous rupture of membranes prior to onset of labor contractions, occurring at or after 37 weeks of gestation. This was called premature rupture of membranes. However, the name premature rupture of membranes was not clear on when this happens and what the consequences of the word premature might mean to the pregnancy. Of interest today, preterm pre-labor rupture of membranes, which is the spontaneous rupture of fetal membranes before onset of labor and prior to 37 weeks of pregnancy, is going to be the focus of our discussion. I just thought I should start with the definitions to put everyone on the same page. Why are we discussing this today? Why is PPROM a topic for discussion today? PPROM is a topic of discussion because preterm birth, as we are going to see the different pathways, accounts for 70% of all perinatal mortality and more than half of long-term morbidity. You can imagine, for all babies born, 75% of them die because they are born preterm. And one half of all long-term morbidity, be it cerebral palsy, be it any other chronic condition, will be as a result of being born preterm. Spontaneous rupture of membranes complicates, like Dr. Sevliba said, 3% of all pregnancies worldwide. The incidence is higher in Africa. We are going to see why. I think if you look at one of the commonest causes, as we shall see in the pathogenesis, infection, vaginal infection is one of the commonest triggers of spontaneous rupture of membranes. And in Africa, one of the things that you will notice is that we haven't paid so much attention to prevention and treatment of vaginal infections during pregnancy, which might increase our incidence on top of other things. Preterm pre-labor rupture of membranes is associated with about 30 to 40%, which is about a third of preterm births. So you can imagine if all preterm births are 75% of mortality and PPROM contributes about a third, which is from other evidence, 30 to 40%, then it is a significant problem. It is a significant problem because if a child is born preterm, there is a significant association with major complications such as neonatal sepsis, respiratory distress, intraventricular hemorrhage, necrotizing enterocolitis, and so many other complications of prematurity, depending on the gestational age, which then makes spontaneous rupture of membranes before labor in the preterm period a leading cause of neonatal morbidity and mortality. There are commonly 4 pathways to preterm birth as a general problem. 4 pathways to preterm birth. There is spontaneous preterm birth, and people, why I wanted to put this in is sometimes people mix these conditions up in their diagnosis. But there is spontaneous preterm birth with intact membranes. So labor can be initiated preterm with intact membranes, not triggered necessarily by rupture of membranes, and that contributes to 40 to 45% of the number of preterm births. PPROM, which is our topic of discussion today, comes in with 25 to 30%. The evidence, there's a lot of evidence on this subject, but if you look at the evidence, most of it varies, but at least all will be between 25 and 40%. So that's the burden, very, very big burden. Many of the preterm births are initiated by you and me for one reason or the other. Maybe a patient comes in and they have hypertensive disorder of pregnancy, and it is showing evidence of end organ damage, and you decide to induce labor, then you medically or iatrogenically contribute to preterm birth for the safety of the mother and the baby. There is another silent conversation that we have to talk about: cervical insufficiency, which contributes 8 to 9%. Cervical insufficiency is characterized by cervical changes, including ripening and dilatation in the absence of labor, contractions, or rupture of membranes. But our focus for discussion will be on preterm, prelabor rupture of membranes. A bit of the science. Before we talk about these membranes rupturing and amniotic fluid leaking, I think we need to talk about the physiology of amniotic fluid. And if we look at it, amniotic fluid is 98 to 99% water and electrolytes. As you can see, it's a clear fluid. The other 1 to 2% is proteins, carbohydrates, lipids, hormones, enzymes, and sloughed fetal cells. The volume in third trimester peaks at around 34 weeks at about 800 to 1 liter. If you look at the production and uptake, you will notice that about 500 mils of amniotic fluid is formed and taken up each hour. So this is a fluid that is having a very high production and uptake. Major contributors to the production of amniotic fluid is fetal urine, and the uptake is fetal swallowing. If you look at the diagram on the right, you will realize that fetal swallowing is one of the biggest contributors to fetal uptake, to amniotic fluid uptake. It takes up about 500 mils. And fetal urine also will produce about that per hour. So they balance out the effect. Other contributors are the lungs. A lot of the times when the baby is swallowing the amniotic fluid, a lot of it will go into the lungs and some of it will come out. But it has a balancing effect in the such that the amount of fluid, which is about 150 to 200 mils, is taken into the lungs and the same amount is taken out. And therefore, why I talked about this is because this is very important and plays a critical role in the development of the lungs. And as you will see, if this fluid is reduced, then you have a risk of both respiratory distress syndrome, but also pulmonary hypoplasia. The other routes of intake and output are normally, they cancel out, meaning that, for example, at the placental membrane, if about 50 mils is being taken in, then 50 mils is being taken out. The umbilical cord also plays a role in formation and uptake, but as I have said, the other routes normally have a net effect, meaning that the amount of fluid they produce is similar to the amount of fluid they take up and might not contribute significantly to the changes in amniotic fluid. I thought this would be important for us to know so that we understand why it would be a big problem if the membranes ruptured and then we had leaking of amniotic fluid. Where does the problem arise? The exact pathogenesis of PPROM is multifactorial and is not fully understood. And I think that is why you see that despite this being a very old known medical condition, prevention has not been successful. Also, treatment, in as far as stopping the leaking of amniotic fluid, has been difficult. Normally, it involves weakening of the fetal membranes. There are a number of factors that contribute to the weakening and rupture of fetal membranes. If you must remember something from the pathogenesis, please remember infection and inflammation, because localized within if infection and inflammation is localized within the membranes, it leads to enzymatic degradation of collagen and extracellular matrices. Inflammation causes degradation of collagen. The membranes are made up of collagen. If you break it down, then you risk rupture because the collagen and extracellular matrix has been weakened. Of course, other factors contribute. For example, you will see that it is a risk to have an increased intrauterine pressure. Polyhydramnios, multiple pregnancies, and uterine anomalies increase this pressure, risking a rupture. Cervical insufficiency, as we saw, is going to weaken the cervix, leading to effacement and dilatation. This exposes the membranes to infection. It stretches out the membranes and then predisposes them to weakening. Of course, one of the significant risks is smoking and illicit drug use. It increases the risk. And the previous history of PPROM. We have all learned that if you are not very sure about the answer of risk factors and etiology, then you can say that a previous history is one of those. However, to note, evidence is not very clear. Evidence does not strongly suggest that if you had previous preterm prelabor rupture of membranes or PPROM, that the risk increases and it ranges from 10 to 35%. However, the risk of preterm birth is even higher, meaning that if you have a history of PPROM, yes, there is an increased risk for the future pregnancy having PPROM, but there is even a bigger risk for the future pregnancy resulting into a preterm birth. This is to look deeper into the science. Maybe I will not go so deep into it, but I put this slide in for people to look at later because, you know, for some mothers, they will ask you why, what happened? And for your students and for your mentees and for your other colleagues, they might ask you why. And if you look at genital infections, that's why it's on top there. They are going to stimulate, you know that any form of infection or inflammation is going to stimulate the innate complement system and the humoral system, and then you are going to have the release of bacterial proteases, which are going to decrease elasticity and cause rupture of membranes. The immune system, if you look on the right, is going to be triggered to produce inflammatory markers and weaken the membranes, and also lead to activation of membrane metalloproteases that are going to break down the membranes, leading to PPROM. Trauma, sometimes at 13 weeks or at a different time, we might want to do amniocentesis, we might want to do any other invasive fetal procedures, and this trauma might lead to rupture of these membranes and lead to PPROM. Genetic factors, of course, always play a role because you know that the genetics are the ones that dictate the integrity of the fetal membranes. So if the genetics are for breakdown of those fetal membranes, then they are going to predispose you to PPROM. Cervical dilatation was talked about. And in a nutshell, this shows you the science of how these different conditions might predispose you or even cause preterm prelabor rupture of membranes, but also induce uterine contractions, as we shall see when we discuss latency. The clinical presentation of PPROM and PPROM is normally a sudden gush of a certain gush or a slow leak of fluid from the vaginal tract. You will see that most patients will tell you their water broke, or they will report a sensation of wetness or dampness. But typically, as we will see, that this is normally a clinical diagnosis. Typically, you have to look and characterize the fluid that you're observing, and it is typically clear, ostro-colored, and odorless, though it can sometimes be tinged with blood or meconium. The diagnosis of PPROM is a clinical one, and it requires that you confirm membrane rupture and also that you rule out other causes of a vaginal discharge. At the facility where I practice, it is very common that a patient is referred with a diagnosis of PPROM, and when you take a thorough history, you find out that they actually have not leaked membranes. When you observe them for about 48 hours, they have no evidence of leaking, and you realize that maybe the referring doctor or doctors did not put a lot of time in taking a detailed history. Very many times, because of pregnancy, a mother might have an increased vaginal discharge, maybe as a result of physiology. For example, mucorrhea. They might have urine incontinence, as you understand the roles of progesterone in weakening smooth muscle that might affect the sphincter or even angling of the closing mechanism of the bladder. So urine incontinence, you must make sure that the fluid that is coming out is not urine. You must take a history for other causes of vaginal discharge that is clear, such as fistulae, and any other reasons. So you must take a detailed history of amount, color, duration, and how everything happened. Many times people miss out the speculum exam, which must be a sterile speculum exam. This is the hallmark of diagnosing leaking of fluid or amniotic fluid from the cervix. And so when you put in a Graves speculum or a Cascos speculum, and you observe in the pouch of Douglas, you should be able to see clear fluid, or sometimes it might be stained with blood and meconium, coming from the os or pooling in the posterior fornix. Of course, to note, you must avoid or minimize digital vaginal examination because it increases the risk of vaginal or maternal infection. As we are going to see, we talked about prematurity on the fetal side, and we are always going to talk about the risk of maternal infection that increases the morbidity and mortality of the mother significantly. So by doing vaginal examinations digitally, you are facilitating the rise of vaginal organisms or even organisms on the vulva up into the cervix that might increase the risk for uterine infection. However, it is not completely contraindicated to do a vaginal exam in PPROM. If you have active labor, where you have uterine contractions, you are allowed to do a vaginal exam to assess and monitor labor. If you have evidence that labor is imminent, delivery is imminent, you must do a vaginal exam to assess and prepare for delivery. Of course, as we are going to see, vaginal bleeding is one of the complications. So a vaginal exam would be indicated in the context where placenta previa has been ruled out, as we know very well that ablapsio placentae is a common complication. Of course, as we know again, cord prolapse is a presentation, and prolapse is a common complication of preterm prelabor rupture of membranes. So if you suspect, for example, a patient comes in and they have been having rupture of membranes, and when you do your fetal assessment, there is evidence of fetal distress or a non-reassuring fetal status, and your thoughts go to a possible cord presentation or prolapse, it is indicated that you can do a vaginal exam to confirm, a digital exam to confirm that diagnosis. I put this in specifically because this is widely ignored or not taken up in the diagnosis of PPROM. In our setting, we normally just take a history, and so many people will not even go ahead to do a speculum exam. And people will not go ahead to do a nitrazine exam or even a FAN test. And this is risky because it predisposes the mother to the risk of intervening when it is unnecessary. So even after you've done your speculum exam, it is very important to do a nitrazine test. And the nitrazine test is based on the fact that amniotic fluid is alkaline, and it will turn a nitrazine paper from yellow to blue. You can see in the picture that I put here, I am demonstrating how that happens. This is not entirely accurate. It can give you false positives. For example, false positives can occur because there is other alkaline solutions that can be in the vaginal canal, such as blood, semen, antiseptics, but also in the context of bacterial vaginosis, as we know very well that in vaginosis is not a vaginitis, and therefore the discharge that you will produce is normally alkaline. In the lab, we can go further to do a FAN test that I have demonstrated on the right. As you might see, if you collect that fluid and you put it on a slide and look at it under a microscope after it has been dried, due to the salt component of amniotic fluid, this amniotic fluid crystallizes and produces a characteristic fan pattern that is demonstrated very well here, and that can give you a confirmation that this is amniotic fluid. Again, like I said, evidence is very clear on the role of group B streptococcus in one, the causation of or the risk of preterm pre-rupture of membranes, but also one of the leading causes of early and late neonatal sepsis. But this is normally neglected in our setting. We don't have screening, and we normally don't have prophylaxis for it. Lucky to note is that very many people are working very hard to develop a vaccine for group B streptococcus to reduce its risk in causing maternal infection that might result in spontaneous rupture of membranes, but also in causing early and late onset neonatal sepsis. So if you have preterm prelabor rupture of membranes, it is indicated that you do a vaginal swab or rectal swab for group B streptococcus if it wasn't previously screened or treated for. And this might guide your treatment. The evidence of the role of ultrasonography in the diagnosis, but also management of preterm prelabor rupture of membranes is clear. You will realize, as we saw in the close-knit formation and uptake of amniotic fluid, that if there is a leak, then you're going to risk the amniotic fluid reducing, a condition called oligohydramnios. And ultrasonography will be key in the diagnosis and quantification of this. It is also key in confirming fetal well-being. As we know, I talked about fetal, the role of amniotic fluid in lung maturity and prevention of pulmonary hypoplasia. But you also know that amniotic fluid has so many other roles that include protecting the baby from shock and so many other things. And therefore, if you have oligohydramnios, then you risk affecting the fetal well-being. And ultrasonography, as you may know, might help with this. It will offer you a fetal heart rate that can give you some context in the well-being of the baby. It will offer you the biophysical profile that includes a non-stress test and other parameters that will tell you about the well-being of the baby. It can offer you other Doppler studies, including the umbilical artery, the mid-cerebral artery, and the ductus arteriosus, ductus venosus readings that might tell you about this. However, there is no role in its diagnosis. So do not try to use ultrasonography to diagnose a rupture. We have already, membrane rupture, we have already seen how that diagnosis is made. So the role is in amniotic fluid quantification and assessment of fetal well-being. I was thinking for a long time that there are two strategies. There is the deepest vertical pool and there is the amniotic fluid index. And I was thinking, what's the evidence? Why these two? And if you look, the deepest vertical pool is less sensitive than amniotic fluid index, but more specific for the diagnosis of oligohydramnios, meaning that if you use the amniotic fluid index, there is going to be ×2 or 2 times higher chance of you diagnosing amniotic fluid index, diagnosing oligohydramnios than if you used the deepest vertical pool. However, that is not entirely a good thing. It means that if you are less sensitive, amniotic fluid being more sensitive but less specific would mean that it is prone to the risk of unnecessary obstetric intervention, meaning that it can wrongly or falsely, positively diagnose oligohydramnios. And therefore, if you have a low index of suspicion, or if you want to be more specific, the deepest vertical pool is more specific for the diagnosis of oligohydramnios. So if you use the single deepest vertical pool and it gives you a diagnosis of oligohydramnios, then most likely that's going to be an accurate oligohydramnios that might warrant your obstetric intervention. Of course, The ranges are written on the side. I just thought that you should know about how to use the deepest vertical pool and the amniotic fluid index in the picture on the side. If you look at this first image, it somehow demonstrates to you how we would check a deepest vertical pool. So you just look out for a quadrant that has no cord or no fetal limbs, and you just take the vertical pool and you realize that that height that you get, if it is between 2 and 8, then that's okay. But if it's below 2, then that shows you that the patient might have oligohydramnios. The amniotic fluid index, however, is taken 4 times. Similar conditions, there shouldn't be anything obstructing, anything occupying that quadrant. You take it in 4 different quadrants, and then a formula will help you in calculating the amniotic fluid index, and that might help you in the diagnosis of oligohydramnios. However, whichever you use, the evidence is very clear that there is no change in perinatal outcomes, whether you use the deepest vertical pool or amniotic fluid index in your diagnosis of oligohydramnios, whilst you are managing preterm prelabor rupture of membranes. Okay, so we go into the management. At least remember what I have highlighted to show that the proper management of spontaneous rupture of membranes before labor is initiated, is aimed at balancing the risks of prematurity against the risk of maternal infection. If you must remember anything, that should go home with you. That in your considerations, you are looking at the risks of prematurity that we have already alluded to versus the risks of maternal infections that we are going to see as we continue. I will start with the simpler or the lesser evil, which is PPROM, meaning that this is spontaneous rupture of membranes at least 12 hours before the initiation of labor. I have put topics of discussion. The first topic of discussion is expectant management versus induction of labor. Both of them are agreed. Evidence shows that both are possible for you. However, if you want to do expectant management, you are riding on the fact that after rupture of membranes, which is called the latency period, after rupture of membranes, averagely between 12 to 24 hours, there will be spontaneous onset of labor. Of course, we don't want to do induction of labor if there is a chance of spontaneous rupture, spontaneous onset of labor, because induction of labor increases the risk, the fetal risk outcome, and the risk of a mother getting cesarean section. So in the place where spontaneous labor can happen and reduce that risk, that is something you can always consider. So there is always a chance to do expectant management where you don't do immediate induction of labor for 12 to 24 hours as you wait for spontaneous labor to happen, if there is, if mother and fetus do not have any complications. Of course, you must be careful, like we said. If this period goes, because starting at 16 to 24 hours, we consider that prolonged rupture of membranes, and prolonged rupture of membranes risks the mother getting an infection. So in a nutshell, it is okay to go ahead and induce labor if you diagnose PPROM, and it is also okay to do expectant management between 12 to 24 hours to wait for spontaneous labor, after which, if it starts, you continue your monitoring, and if it doesn't happen, then you go ahead to induce your labor. There is, I was looking at a lot of evidence that is starting to crop up to talk about, I forgot to talk about the latency period. We are going to realize latency period is the period between spontaneous rupture of membranes and onset of labor, if spontaneous rupture of membranes starts before labor starts. And it is negatively correlated to gestational age, meaning that if a mother is at 32 weeks and they get spontaneous rupture of membranes, their latency period might be longer than a mother who is 37 weeks or 36 weeks. and they get spontaneous rupture of membrane. So, which is not a bad thing, because then we have enough time, we can buy some time to give whichever medications we need to give, and also to carry the pregnancy on a little bit longer to reduce or even prepare for the risks of prematurity. The evidence between home care and hospital care is insufficient. And in our setting, we should, it is advised in a setting like our own that we do hospital care because of the monitoring that is supposed to be done if a mother has this condition for both the fetus and the mother, and we might not have the resources and the level of commitment and understanding on the mother's side to be able to monitor from home and quickly transfer to the hospital in case of a complication that can happen very fast. In PROM, prophylactic antibiotics are not generally recommended unless there is a history of positive GBS status in the mother. Now we go to pre-PROM, and I've also discussed it in the headings that are very sensitive that we need to discuss in today. One of the things that we need to discuss is expectant management. Expectant management is management that does not include interventions that initiate immediate delivery. And for pre-PROM, we know very well that we are trying to balance the risks of prematurity and the risks of maternal infection. And as we saw that beyond 37 weeks, the risks of prematurity are very low. So we should go ahead in most cases and induce or wait for a very short time for spontaneous labor to occur because the risks for prematurity are not very high. And so waiting longer might not be beneficial. But in pre-PROM, and as the gestational age reduces, conservative or expectant management plays a key role. And expectant management should be in a hospital setting where you can monitor both the fetus and the mother, because this is a progressive diagnosis whose management changes as monitoring of both the fetus and the mother continues. Of course, you have to compare the risks of prematurity with those of chorioamnionitis. And this is, and if the risk of chorioamnionitis is overriding that of prematurity, or if there is evidence of an infection, then you terminate the expectant management. Antibiotics are a mainstay. Antibiotics are a mainstay or a must in treatment of preterm prelabor rupture of membranes because they prolong latency. They give you time to give your corticosteroids. They give you time for the baby to mature, sometimes 10 days. There is evidence that has shown 2 weeks. And this is very key to a baby, mostly for those babies that are in extreme prematurity. And it has shown that if the latency is prolonged, it reduces both neonatal morbidity. And the antibiotics are going to reduce both maternal and neonatal morbidity. The antibiotics of choice, all studies have shown that macrolides are best at achieving prolonging of latency and preventing maternal and neonatal morbidity. So it is not just a choice you're making to pick a macrolide, it is evidence-based. Please don't pick anything else. It is very common that people are giving ceftriaxone, people are giving all other sorts of antibiotics, and yet the evidence is clear that a macrolide, starting with erythromycin and clarithromycin, are the mainstay. I didn't mean to write ampicillin there. I meant to write azithromycin. However, evidence also supports the use of a combination of ampicillin with amoxicillin in combination with a macrolide. So please remember that your first line is always a macrolide, but where you might need it, you might combine a macrolide, for example, erythromycin with ampicillin and amoxicillin. Forgive me for that, this had to be azithromycin. The duration, one of the things we will see in the gray areas of the management of pre-PROM is how long do you give antibiotics? How long does expectant management go on for versus the risk of infection? And if you look at the evidence, there is no data that supports the use of antibiotics beyond 10 days. I'm not saying that that's the duration through which you should do expectant management. That depends on the fetal and maternal well-being, but the use of antibiotics beyond 10 days is not going to help you prolong latency or reduce maternal or neonatal morbidity. I think that's the conversation that we needed to have about antibiotic use. We will see the role of, these are oral antibiotics. By the way, many times you see people putting IVs, you see people doing other things, but the route is per oral. You have to, these are oral antibiotics for prevention or prophylaxis. And we shall see that intravenous antibiotics then come in or play a role when we have an active infection. Antenatal corticosteroids are another heavily used, sometimes abused medicines in pregnancy. However, they are only indicated between 26 and 34 weeks and 6 days. There is no role for giving corticosteroids between 34 and 36 weeks. It does not improve neonatal morbidity or reduce neonatal mortality. So it is not useful. It is a drug you're going to give to the patient, and it's not going to benefit them. And there is evidence that has come up recently that shows that corticosteroids are not entirely safe and have been shown to be associated with long-term side effects such as delayed mental development and retardation, for lack of a better word. We don't like to use such language anymore. And the purpose of giving corticosteroids, if people may be wondering why, is that it plays a key role in fetal lung maturity. It reduces the risk of respiratory distress syndrome, it reduces the risk of intraventricular hemorrhage, and it reduces the risk of necrotizing enterocolitis. As you can see, the evidence is in one slide is quite heavy, and we might not put a reference for each and every one of them, but I will share a guide for which members can look and understand these facts and how they were arrived at, if I am advised to do so. Tocolysis is another controversial topic. Tocolysis, you will see that very many people, when they get PPROM or make a diagnosis of PPROM, they're going to run to try and do tocolysis. It is not routinely recommended unless you have preterm labor. It has a role in preterm labor, but not preterm pre-rupture of membranes. And its role in preterm labor is only to ensure that you stop the contractions for at least 48 hours, such that you can give the antenatal corticosteroids, but also it gives you enough time maybe to transfer the mother to a tertiary center that might might have better neonatal services. Tocolysis, the best and evidence supports that number one of first-line use is nifedipine in a patient who is not hypotensive. It shows that it works best. Different guidelines give different doses, but you start with a single dose of 30 milligrams, and after you give 20 milligrams every 8 hours for about 48 hours. There is a role of magnesium sulfate in tocolysis, and the dose is about 6 milligrams IV, and you can give a maintenance dose IV, but that is not very effective in achieving tocolysis. There is a role of use of terbutaline, but a take-home message is that if you need to do tocolysis, your first-line agent that has been proven to have the best success should be nifedipine, and I have highlighted a bit about the dosage. Magnesium sulfate is another talking point. Evidence is very clear on this one, that between 26 and 32 weeks, it has a role in neuroprotection. However, it is abused as well in so many clinical settings, because the role is only if delivery is anticipated within 24 hours. So if you have a patient with PPROM and you're still giving antenatal corticosteroids, and you know that you might have a latency of about a week because the cervix is closed and there are no cervical changes and the fetus is okay and there are no signs of maternal infection, you delay giving magnesium sulfate. Otherwise, if you give it and the delivery is not within 24 hours, its role in neuroprotection cannot be, is not evidence-based. But also its role beyond that, by evidence, is not there. I think that is the discussion. Oh, the dosage. The dosage is 4 to 6 milligrams intravenous. 4 to 6 grams intravenous. Of course, if you go to different guidelines, they will give you different doses. But if you have 4 to 6 grams IV, I think that will fit in most guidelines, as you might see in your reading later. Monitoring is the hallmark of expectant management of PPROM. Monitoring is the hallmark of expectant management of PPROM, and it tells us when to stop or when to deliver. And what do we monitor for? We monitor for signs of infection. The mother might develop a fever, uterine tenderness, a foul-smelling discharge, elevated white cell count, fetal tachycardia, as we shall see when we discuss that a bit later. We also monitor for fetal well-being. Remember that the fluid is reducing. We are getting maybe mild, moderate, severe oligohydramnios or even anhydramnios, and this might affect the fetal well-being. And therefore, fetal monitoring by continuous cardiotocography, doing a non-stress test, or by physical profile is key in the expectant management of a mother with PPROM. It is common that you will hear people telling mothers with PPROM to rest or not move or stay in bed or stay in a recumbent position. I am here to tell you that evidence does not show any benefit in the setting of preterm prelabor rupture of membranes. And however, as we know very well from the virtuous triad, that stasis that might be associated, of course, this is a double jeopardy. You have an inflammatory process that might be because of an infection. You have a pregnancy process that causes hypercoagulability, and then you are telling the mother to stay in bed completely for a week. This might predispose them to adverse maternal effects, including thrombosis. Delivery. Of course, we saw that one of the biggest scares that we get when we get PPROM is that at some point we will have to deliver the mother. Delivery is indicated in these 3 circumstances. 1, maternal or fetal infection. 2, evidence of fetal distress or compromise, or a non-reassuring fetal monitoring. 3, if a gestation reaches term. For example, if you decided, as we shall see, if you decided to do conservative management between 34 and 36 weeks, and now it is 37 weeks, the role of conservative management stops and immediate delivery becomes an alternative you must take. Between 34 and 36 weeks of gestation, many guidelines recommend immediate delivery. As we said, it is always a measure between the risk of prematurity and the risk of maternal infection. And you know very well that at 34 to 36 weeks, the risk of maternal infection, the risk of prematurity reduces significantly because we have reached a point where we expect fetal maturity. So many guidelines will tell you that if it is between 34 and 36 weeks and you get PPROM, deliver immediately. However, you know very well that these days medicine is not about decree. Decree means that you tell, if it happens like this, you do this exactly. In certain instances, for example, initiated by the mother or for any other reason, expectant management to 37 weeks is accepted in certain settings. but immediate delivery is in many guidelines. And that is why I put a second bullet saying that evidence is conflicting for the timing of delivery. A lot of evidence will tell you immediate delivery because the benefit is not bigger than the risk. But some will tell you expectant management is still an option in the hospital setting. Below 34 weeks. Below 34 weeks, I think, is a no-brainer. Expectant management to allow fetal maturation, provided no signs of infection or fetal compromise, would be good. Vaginal delivery is recommended. Vaginal delivery is recommended even in the setting of oligohydramnios, even if it is severe, even if there is anhydramnios with no evidence of fetal compromise, even in the setting of chorioamnionitis. I want to say that again, that vaginal delivery is recommended even in oligohydramnios, even in severe oligohydramnios and chorioamnionitis. It is common in our setting today that when a patient gets preterm prelabor rupture of membranes, people are going to offer a cesarean section. But evidence is clear that a cesarean delivery does not improve neonatal outcome above 28 weeks of gestation. If the only reason you're doing a cesarean section is because of PPROM with no other obstetric or fetal indication, and it is above 28 weeks, that cesarean section is not going to improve your neonatal outcome. And there is a very growing body of evidence that shows initially we thought that below 32 weeks and maybe below 28 weeks, there's an increased risk of CNS compromise, for example, complications such as intraventricular hemorrhage and later on cerebral palsy and so on. But evidence is showing that above 28 weeks, that is not the case. There is even evidence that is coming up to show that even below 28 weeks, that might not be the case. But, you know, for a consensus, and we might go into a discussion after this, 28 weeks and above, you are safe to do a vaginal delivery without worsening your neonatal outcome. Induction of labor is safe, even with dinoprostone. Most people will tell you, no, the fluids are leaking. Where am I going to insert the dinoprostone? Studies are clear that dinoprostone works perfectly in this setting of PPROM, and that it is a good way to induce. Studies are clear that both misoprostol and dinoprostone have similar outcomes, and therefore your considerations should be based on the cost and other things. And so if you choose to use any method that you want to use for induction of labor, you are justified. Prepare for the baby. I know that my colleagues, the pediatricians, are always telling us how we prepare for the baby. So I won't go into details, but always, always prepare for the baby. Don't focus on delivering the mother and not knowing what you're going to do for the baby. Most times what people do is they rush the mother to theater, take out the baby, and then the question of what do we do for the baby starts. So plan before you conduct the delivery. Of course, before 26 weeks, which is deemed previable or before viability, is very contentious. In our setting, the diagnosis of an inevitable abortion is made. Of course, like I said, the era of medicine where we make decree is slowly dying out. So even in this setting, you must advise the mother very clearly that the risk of neonatal morbidity is very high. Pulmonary hypoplasia, severe infection, perinatal death, cerebral, both immediate, short-term and long-term. You should counsel the patients about prognosis. Tell them that their baby is not likely to make it. Of course, some mothers or some families might still want to give the baby a chance, and you cannot refuse them. But you must know, and they must understand, that the prognosis is poor and the termination of pregnancy might be beneficial to them. But also, you keep monitoring if they have decided, and if you see any symptoms of maternal infection, then termination is a must. Okay, I have been the whole morning, I have been threatening everyone about maternal infection. So I thought I couldn't go without saying a thing about it. Choriamnionitis, which is on the other spectrum of the mother. It is an infection or inflammation of amniotic fluid, the placenta, fetus, or its membranes. The average time of onset after rupture of membranes is about 16 to 24 hours. Labor onset after rupture of membranes, if you think about it, because you have to know how much time you have. About 50% of the mothers that have rupture of membranes spontaneously will get labor in about 24 hours to 48 hours, and about 70 to 90% in 7 days. Maybe the bullet before was showing onset of infection. So evidence shows that an infection is more likely to set off or to start between 16 to 24 hours after the onset of rupture of membranes. I thought this is important because fever in itself cannot be used in itself independently to diagnose choriamnionitis. So because a mother can have an isolated fever, a mother can have malaria, a mother can have, a viral fever. So for you to make a proper diagnosis of choriamnitis, you should have a temperature. Normally it's high grade. Guidelines will say 38. Some will say 39 degrees Celsius. But they should also have an associated clinical sign. And I have listed them down for you here. Fetal tachycardia, maternal leukocytosis. Of course, we know that in pregnancy, the white cell count increases, so put that into consideration. Of course, a prurient fluid discharge from the os, maternal tachycardia, uterine tenderness, and a confirmed infection. Please, if you have a mother with a fever, look out for these with evidence, and if you have at least one, then you can make a diagnosis of choriamnionitis. Evidence has been clear that serial monitoring of white cell count, for example, if you make a diagnosis of maternal leukocytosis, it has no benefit to keep checking it. Okay? If there is absence of other clinical infections, like I said, if it is only one isolated figure, it might not give you the diagnosis of choriamnionitis. In the setting of choriamnionitis, delivery is recommended. There is no expectant management. Immediate delivery is indicated. And when I say immediate delivery, I do not mean cesarean section. I mean vaginal delivery by induction of labor if spontaneous labor has not already set in. Of course, there is a mammoth of evidence showing that cesarean section is reserved strictly for standard obstetric complications. Because cesarean section solely does not reduce the risk, does not improve. If a cesarean section is solely done because a mother has an infection, it does not improve neonatal outcome, but increases significantly the maternal surgical morbidity. I think we know this very well. If you work on a mother with choriamnionitis, we did a study in Kawempe, and maternal infection came number 3 after obstructed labor and referral in the risk factors for surgical site infection, including the deep surgical site infection, such as pelvic abscesses. So do not do a cesarean section unless you have an obstetric indication, for example, fetal distress or obstructed labor or something in that line. In the space of choriamnionitis, do not delay delivery. Do not delay delivery to complete the course of antibiotics. Do not delay delivery to give magnesium sulfate. Do not delay delivery to complete the course of antenatal corticosteroids. And of course, watch out for uterine atony and PPH as infected tissues have a higher risk for poor contractility. Of course, antibiotic therapy in the space of choriamnionitis is no longer oral, like I alluded to, it is intravenous and broad spectrum. And this will follow your hospital antimicrobiogram, your country's guidance, and the antimicrobial patterns and how they respond to infections. In our setting, we are still using ceftriaxone, which is showing a lot of resistance. We had a very long conversation about that. I think people are moving away from it and going to others, but also people are putting a lot of effort in making sure that we rationally use antibiotics so that this does not continue to become a problem. And the use of antibiotics is upon suspicion, not diagnosis. So even if you're suspecting with the criteria I have given you, because diagnosis is only by biopsy of fetal membranes or the placenta. Okay, what are some of the controversies, advances as I conclude? We are not still sure. Evidence still does not know well the optimal duration of antibiotic therapy. Antibiotics, yes, are recommended, but we don't know how long. It is still debated. How long should conservative management be? If chorioamnionitis happens, doesn't that increase the risk of perinatal mortality in the space of prematurity and neonatal sepsis? Those are questions that we need to answer. The role of amnioinfusion. Of course, we know very well that in cases of severe oligohydramnios, mostly in mid-trimester pregnancies, amnioinfusion has been explored to try and reduce the risk of pulmonary hypoplasia. It is still very controversial and the benefits are not clearly indicated and the guidelines do not pronounce themselves clearly on amnioinfusion. So at the moment, that's not an option that you should look at, but the people who are interested in science might continue to explore how this might revolutionize the treatment of PPROM. Predictive markers, of course, we know everywhere people are looking for predictive markers because if you predict, then you can prevent or prepare. If you can predict, then you can prevent or prepare. And a lot of work and evidence is cropping up in trying to identify biomarkers for predicting PPROM that might lead to more targeted interventions. Of course, we have seen that infection and inflammation are top of the causes or risks for PPROM. So a lot of people are looking into the characteristics of the vaginal microbiome and how infection and inflammation, how they relate to the environment and cause inflammation and infection. And we feel like if we find a solution in this line, we might get potential interventions in prevention of PPROM. As I conclude, I know I have spoken a lot, but I have said that prompt and accurate diagnosis of PROM or PPROM is crucial for optimum management. That's why I was emphasizing history taking, examination, tests, and other monitoring modalities. As we have seen, management strategies are highly dependent on gestational age, and the mainstay is balancing the risk of prematurity against the risk of infection. Of course, in PPROM, expectant management with antenatal corticosteroids, prophylactic antibiotics, close monitoring for maternal and fetal well-being is the way to go. We have talked about digital examinations and when not to do them. And finally, this condition has a very big mental burden, psychological burden on the mother, and therefore on the mother and the family, and therefore in whatever decisions you're making, in whatever risks you identify, in whatever prognosis you think, please communicate with the mother and the family so that they share in decision making, but also so that you prepare them in the realm of management of PPROM. I hope I have talked about most of the things, and I hope I have reminded you a bit about PPROM, or maybe I have also added to your body of information. Thank you very much.
Wow, thank you so much, our expert, Dr. Ssenyondo. Members, I must agree we should give Dr. Ssenyondo his flowers right now. This was well done and well thought out through. You can use that chat section to send his flowers. I'm sure at the end of this session, we shall have several takeaways that will improve the practice, our practice of management of PPROM. We have had several chat. We have had several chat messages that have come in, and we have an experts who have been answering some of them. Thank you so much, Dr. Ndozira, for taking that up, and I think several of them will be answered by Dr. Ssenyondo. Before we go into the chats, I have seen a hand. Dr. Jingo, you had a hand earlier. Can you unmute? You're given a chance to say something. Dr. Jingo?
I'm sending him a request to unmute.
Okay.
Yes.
Ask lower hand. Dr. Jingo, you can unmute. And then you talk. Yes, there he is.
Yes. Thank you so much, Dr. Sebuliba, for giving me this chance. I want to first of all thank Dr. Ssenyondo for the very, very, very good, wonderful work he has done. You know, for me, when I hear people talk about evidence-based medicine, they become my friends, even if I've never seen them. On a light note, I will start by saying that when I first heard Dr. Ssenyondo speak, I thought it was Dr. J.P. Bagala who was speaking. The voice sounded to be similar. Apart from that, okay. That is interesting. I thought it was Dr. JP was speaking. But our colleagues and Dr. Ssenyondo kindly allow me for us to spend a few seconds when it comes to antibiotics. I've grown up to the age that I have now. I've never seen us do GBS screening among our women. And therefore, it means that for us, we have no option. We have to give antibiotics. And we know the problems of irrational antibiotic use. For PPROM, regardless of when it has happened, since we are talking about evidence-based medicine, these matters must be on antibiotics. IV ampicillin, 2 grams every 6 hours for 48 hours. If you are lucky and you are in a center which has 1 gram of azithromycin, give it as 30 dose. Meaning that for those mothers who are on conservative management and they have gotten the IV ampicillin 2 grams every 6 hours, and they have gotten the 1 gram of azithromycin start, after 48 hours, they can go ahead and complete the 5 days of amoxicillin. If you're in a center, which most of us are in, and we cannot give the 1 gram of azithromycin, after giving the ampicillin 2 grams IV every 6 hours for 48 hours, then we are supposed to give erythromycin plus some amoxicillin. I know some of us either give erythromycin alone or give amoxicillin alone. That shouldn't be the practice. The evidence is if you have not given the erythromycin 1 gram start dose, then the patient has to be on erythromycin and amoxicillin for 5 days. And the reasoning is simple, because amoxicillin will cover some microbes, and then erythromycin will cover the other atypicals and the rest. When it comes to PROM, because also doctor has talked about it, for PROM, all mothers with PROM, so long as they reach the 18-hour mark, that will be now prolonged PROM. They need to be on IV ampicillin so long as they are at 18-hour mark to prevent for GBS prophylaxis. Now, I don't know where this system of IV ceftriaxone or ceftriaxone came from. It is not necessary. Actually, we are doing more harm than good. In fact, some people go ahead to even add metronidazole. You are actually doing nothing. You are actually doing irrational antibiotic use. Ceftriaxone has so many problems that you are creating by using it. Now, doctor also talked about the steroids. Of course, since we are in this region, WHO FIGO says we should give up to 34 weeks. But of course, if you work with somebody who's an American who is reading the ECHO guideline, those people are insisting that we can even give up to 36 weeks and 6 days. Of course, I don't agree with that, but I just want to make sure that since we are talking about evidence, the next time you get somebody who's giving it and then they are putting out the ECHO guideline, don't get surprised. ECHO for it goes up to 36 weeks and 6 days. But of course, being that we are in this part of the country, probably will be guided by WHO and FIGO, and for us, we are giving up to 34 weeks. When it comes to magnesium sulfate, colleagues, of course, what Dr. Ssenyondo has presented probably is coming out of a COG up to 32 weeks. However, WHO and FIGO says we can even give up to 34 weeks for neuroprotection. The dose is supposed to be 4 grams IV start and then 1 gram every hour for 24 hours. Of course, for you to get the benefits, delivery has to occur within 24 hours. I was happy to see the slide about chorioamnionitis. Once you diagnose chorioamnionitis, the antibiotics, the evidence is triples. It has to be ampicillin, gentamicin, and metronidazole. Now, people who are giving ceftriaxone or ceftriaxone, I don't know where you are getting those things from. I beg to submit. Thank you so much.
Wow, thank you so much, Dr. Jingo. You're known for the love for evidence, and this has been demonstrated from your talk. And thank you so much for those additions and clarifications. Members, we must agree that this is about evidence, and evidence is informed by research, which goes into guidelines. You might find some guidelines by WHO give a different advice, while others by ACOG and the Americans give different advice. So as long as you follow the current evidence and guidelines, you are good to go. We have some chat questions. Dr. Ssenyondo, something came up about the role of fluids. And I think the person who asked this was coming from the point of a setting of oligohydramnios. Do we have a role as you wait for antenatal corticosteroids and as you consider delivery? Is there a role of IV fluids?
Thank you, Dr. Sebuleba. The evidence does not support does not support IV antibiotics in improving neonatal outcomes, because that is what I think you would be trying to achieve. One, it is not going to increase the amount of amniotic fluid. The rate of loss is going to always be faster than the rate of production. If you're using it for intrauterine fetal resuscitation, we know very well that by the time you do intrauterine fetal resuscitation, you have diagnosed the non-reassuring fetal status. So you are just bridging to delivery. So that would not be expectant management. So no, there is no evidence that if you give fluids, you're going to better the outcome of mother or baby in the setting of PPROM.
Thank you so much. Yes, there's some other controversy. We have talked about the issue of latency, also the issue of resealing and fluid reaccumulation at that time when we are managing PROM conservatively. And that brings in a question of someone who asked about the repeat dose of corticosteroids, especially. I know Dr. Ndozi answered that, but Dr. Ssenyondo, I want you to echo this. If you choose to do conservative management and somehow the amniotic fluid is still adequate beyond 14 weeks, or the membranes still, if the membranes somehow reseal. First of all, is there any evidence that the membranes can reseal? And if it's after 14 days, what happens to the corticosteroids? Is there evidence on this?
So doctors, thank you for that question. It's a very good question. But one is that I have not found any evidence that either membranes are going to seal spontaneously after rupture, I have also not found any evidence that there are products that are going to be used. Of course, very many things have been attempted, but there are no products that are approved or evidence to seal amniotic fluid after spontaneous rupture. And if you think about it, if you put a foreign body, you're going to increase the risk for choriamnionitis. Maybe about a repeat dose. When you look at expectant management of PPROM, when I was looking at it, one of the questions that I had to ask myself is how long? How long? But if you look at, even in the space of prophylactic antibiotics, many times there will be evidence of infection after 10 days. So evidence hasn't gone far to discuss the role of repeat doses in the prognosis in PPROM, but there is growing evidence that shows that repeat corticosteroids have long-term negative impact on the fetus.
Right. So yes, I think this is one of the controversial issues that there is no clear evidence. There are some guidelines that they may tell you that after 14 days, you can repeat if you think you may still deliver before 34 weeks. However, I think what we should advise is that you should know that any multiple doses of corticosteroids have more harm. So as you deal with this, if you're to repeat a dose, let it just be one more dose. But if you choose not to repeat, then the better. There is the evidence of resealing came up from the fact that when there is amniocentesis, at times the membranes reseal. I know that's a small needle used. So in case the leakage is something tiny, some colleagues have talked about resealing and fluid reaccumulation, but this is something else that is still controversial. We have another question. Someone asked about
Dr. Sebuliba, I can ask the question.
Yes.
One of the questions someone asked.
Yes.
Someone wanted to know if how long it would take us to do induction of labor in choriamnitis. I think Dr. Henry can.
Yes, Dr. Henry.
Would we induce labor in choriamnitis? If we are to induce labor, how long should this?
Okay, so delivery is immediate in choriamnionitis. That means that the minute you make a diagnosis of choriamnionitis, you initiate induction of labor if there are no contraindications to vaginal birth.
Thank you. Someone asked about the risk of amniotic fluid embolism. Wow. Dr. Ndozire or Ssenyondo, can you take that up?
I know Dr. Sebuliba made the heading evidence-based, but yes, we know that rupture of membranes has a risk for choriamnionitis. However, I did not get a lot of details on how this plays out in the space of PPROM in spontaneous rupture. Someone could come in for that.
Okay.
I think the question was on amniotic fluid embolism and membrane rupture.
Yes, I might have said something wrong, but yes, artificial rupture of membranes and spontaneous rupture of membranes are both associated with amniotic fluid embolism. However, I can't discuss that further in the space of PPROM and how that affects the mother and what the risks are. No, I can't.
Okay, thank you. I think there is no evidence on that, and the actual event of amniotic fluid embolism is quite rare. So I think that is answered. Then someone asked about Actim. I saw Actim Plus. I don't know whether you're familiar with that as a diagnostic tool.
Oh yes,
Actim
so that is a commercial.
Yes.
That is a commercial test that uses immunofluorescence, I think. Those are commercial tests mostly used in research to make a proper diagnosis and have not yet been extrapolated a lot into clinical practice.
Okay, so they may. I've seen some being commercially marketed around in Uganda, but I think they are not yet into our core clinical practice. Members, if you have a question and if you have to add anything, please, you can unmute or you can raise your hand and you'll be given a chance.
Dr.
Yes?
Sebliba, I think Dr. Ssenyondo can, I know he had alluded to it, the dosages for tocolysis. There's someone who wants to know how much would you use if you're using nifedipine or any other tocolytic, and does magnesium sulfate work as a tocolytic?
Yes, Dr. Ssenyondo?
Yes, I knew that question would come. So there's a lot of controversy on dosing of, first and foremost, the most effective is nifedipine from research. Number two is the dosage. The dosages are different. Actually, I saw someone in the chat talking about 30, but I've also seen 40 and others that the 30 will drop. But normally, maybe we will do a study in our setting. I don't know if we have done that study in our setting, but when you look at evidence, which is very big, and this has been done with so many other women, with the evidence shows that 30 and then the 20-20-20 every 8 hours for about 48 hours is safe. It's not going to cause hypotension, but you're going to monitor for it in case it happens. You know how to manage. And others. The others, terbutaline and magnesium sulfate, are not as effective as nifedipine, but can also be used as alternatives in tocolysis, if I answer the question.
In fact, because of the risk that you have with magnesium sulfate, it's not very recommended. It might have had an effect on tocolysis, but it has other side effects that are not that you could avoid if you used other tocolytics. So because of that, it is not really recommended for tocolysis. You can give it for neuroprotection to prevent convulsions and other things, but autocolysis shouldn't be used routinely. Otherwise, we're going to expose women to toxicity.
Yeah. Okay. Thank you so much, Dr. Ndozire. There is someone called Kilama. Dennis, I think you had a burning question. Can you unmute and I think you'll be the last speaker. Members, we have 3 minutes before we give the takeaways and conclude our session. Kilama, you're given a chance. Dennis? Okay. Okay, maybe Kilama Dennis, as we wait to come in. Dr. Ndozire, do you have any other question?
Yes.
Because we should be finishing in the next 3 minutes.
Yes, I would like Dr. Ssenyondo to talk about this. We have discussed it before. Someone is asking how one go about mild, moderate, severe oligohydramnios. How do we classify oligohydramnios? That's, I think we can answer that one. Then what percentage of magnesium sulfate is used for neuroprotection? Is it 20% or 50%?
Dr. Sebliba, I'm here. Can I say a thing? I wasn't permitted to.
Please go ahead.
Yeah, I just have to re-echo a question on the doses of nifedipine. Doctor tried to give the dosing of nifedipine, but still there's a question on the chat which is not clearly answered. The concern is about blood pressure. That even for a normotensive person, if you give nifedipine 20 milligram or 10 milligram, their BP lowers. Now, given this situation, you're giving nifedipine 30 and or 40, and you continuing to give 8 hourly. And we having risk of hypertension with that. Then the last one, which I still copy is of important. If you screen someone having severe oligohydramnios, you screen, there's no infection, but they have had the PPROM. Could you continue to monitor if their amniotic fluid index will increase, and really, how long could you monitor that? Thanks.
Okay, I think that's our last question. Dr. Ssenyondo, do you think you can take up any of those?
Yes.
About the dosage and hypertension.
Yes, thank you so much for that question. And I understand your concern. and your logic comes from a good place, but fortunately, it has been shown that these doses are not going to cause you hypotension. But also, I have used this myself, and the patients have not had hypotension.
Got hypertension.
So, doc, you might be comfortable with that. But also about oligohydramnios, the goal in management of PROM, in conservative management, is not necessarily so that the amniotic fluid index improves. That's not one of the goals. The goal is to prolong, even if it might be reducing, as long as the fetus and the mother are okay for as long as possible. Of course, we talked about mild, if we're using AFI, is 5 to 8 centimeters, moderate is 2 to 5, and severe is less than 2. Why we are not, why that is not, why that might not be very critical in our decision making is that it might not change the management or delivery plan in a space of a baby that is not showing features of compromise, or a mother who is not showing features of infection.
Well, thank you so much, Dr. Ssenyondo, for answering those. I hope everyone has benefited. I must say there are several takeaways from this webinar. We've seen that we need to minimize digital exams, colleagues, on the labor ward. If your colleague has already admitted the mother and done a diagnosis with a speculum, then there is no role of doing a digital exam, unless if you suspect the woman is in labor. If you must examine her, use a speculum, a sterile speculum. Please minimize digital exams. Then another takeaway was we've seen the deepest vertical pool may be more specific, especially if you're dealing with obstetric interventions compared to the amniotic fluid index. Antibiotics, we've highly discussed these. Dr. Jingo has given his remarks, and we said kindly avoid ceftriaxone. I think we are just using ceftriaxone because it's easier to give. It's once daily. But colleagues, it is not recommended to use ceftriaxone. If you're so lazy to give, at least use in this setting, but we can't use. Then magnesium sulfate, we also said it is highly abused. Within the next 24 hours. If the patient is still in that latent phase, if there is still latency, there's no role in using magnesium sulfate. Remember, it has its complications. And they said the safe dose is our IV loading dose. Bed rest has no evidence. Of course, it's perceived that the mother, again, bed rest has no evidence. We emphasize the role of shared decision making, involve the mothers in every decision you make. It's not a decree like Dr. Ssenyondo said, but let's involve the mothers. We said choriamnitis is immediately delivery and cesarean section. Again, cesarean section is not going to improve neonatal outcomes. Only do cesarean section if there is a clear obstetric indication. Dinoprostone, let's not fear to use dinoprostone in this setting. We have a fear that, it will flow out. It's still a good drug to induce labor. And lastly, we are going into the era of GABS screening, and also several researchers are doing vaccine studies. Some of them are taking place in Kawempe, and we shall be providing evidence as it comes in. Again, members, send the flowers. Allow me to thank Dr. Ssenyondo, for our expert for today, for taking us through this. And I want to wish us a good day. This recording is available after a few days on the KLMNS website. You can go and review our discussion. Thank you so much, Dr. Ssenyondo and our colleagues. Please have a nice day. Thank you.